Good afternoon, everyone, and welcome. Welcome again to our Ask the Physician program. Most of you know me. I'm Dr. Larry Wright with the UAMS clinic here at Butterfield Trail, and we so enjoy this monthly presentation that we get to offer you. We try real hard to make it relevant, something that will be interesting for all of you. And I think we've done a pretty good job of that, of topic selection today. So as most of you know, but in case you're new, I'll just describe every month. So we have four-week blocks year-round. 4 weeks at a time. We have 2 resident physicians here at Butterfield Trail with me, seeing patients in the clinic and in the healthcare center. And so it's these 2 residents this month that will be presenting today's talk, which is about rhinitis and problems with the nose. Don't blame them for the title, Woes of the Nose. I know that makes people groan, but that was my creativity. So anyway, we're going to be talking about all things problematic with the nose. I want to introduce the 2 residents we have because some of you have seen them this month. This is their last week here for this block, and then we'll have 2 new different residents next month. These 2 guys I've gotten to know really well. They're both 3rd years, so they're in their last year, now their last few months in our training program. And just as a reminder, our training program is a 3-year internal medicine residency. So after getting their medical degree 3 years ago, then 3 years of training that has them prepared to be practicing internists. In the case of these 2 guys, they're not going into practice. They're taking on at least 2 more years and possibly 3 more years of training, doing a specialty fellowship. So let me tell you about the 2 of them. And the first one to present will be Dr. Jay Patolia to my right. He has, again, been with us 3 years. Jay grew up in Houston, but actually he grew up, he was born and raised in India before immigrating at age 12. And then has lived in Houston since that time, and we were very lucky to get Jay Patolia in our program. He's been a real star, and his future the next couple of years will be at Kansas University in Kansas City, preparing to become an allergist immunologist. So we're very proud of that, and Kansas University is one of those outstanding state university medical centers and medical complexes. So he's got a bright future doing allergy. And then when he finishes his first half of the presentation, he'll be followed by Dr. Jimmy Vo, who you can tell by looking at him, he's a native Arkansan. He grew up in Fort Smith area and went to UAMS. And he has also an outstanding fellowship that he's about to enter come June. He will be moving to New York City. Now, he's been all these years in Arkansas, but now he's going to be in New York City for 2 or 3 years studying endocrinology. You know, that's diabetes and thyroid and all the glands and hormones. It's a very important subspecialty field of medicine, and he is going to be matriculating at none other than Columbia University, one of the really, truly outstanding medical complexes in this country. So we're proud of both of them. You're going to hear from both of them now on what I think is such a common affliction that we all have notions about it and run into it periodically, and I think there's so many misconceptions about it for that reason. So I thought I would task them with the charge of bringing clarity to what can be kind of a confusing and bothersome affliction. So with that, we'll hand it over to Dr. Patolia.
Hello, everybody. Again, I'm Jay. I am not as eloquent as Dr. Wright, but I think we'll try to get this presentation as fun and nicely as possible. All right, so hopefully you guys can see all the slides. The title slide, again, that's Dr. Wright's creativity right there, Woes of the Nose. And we have some cute little pictures attached just so we don't bore you with just plain text and a lot of reading. You'll notice that our slides don't have a crazy amount of words, and that's designed specifically so that you can read kind of like the summary of what we're about to talk, and that way you can pay attention to what we're actually talking about rather than trying to read some small words on a slide on TV. Alrighty, so let's start off the topic with rhinitis. It's nose stuff pretty much, and I think most of us know that it's related to the nose. It's not really derived from baby rhinos, but it is derived from the Greek word rhinos, which is nose, and itis usually refers to like irritation or inflammation. So technically it is baby rhinos, but it's nasal irritation. That's why it's rhinitis. There we go. Okay, so some science stuff. Like we just said, rhinitis is inflammation of the nose. So usually your nose has a few functions. Obviously the main one is breathing, but the inner workings of the nose, you know, the tissue and the hair and stuff that you've seen throughout your life, that kind of functions to make sure that the air that enters your nose and into your lungs is humid, and the air, the hair and the mucus that are produced in your nose pretty much function to act as a filtration system to trap dust, pollen, etc., any kind of foreign particles, so that your body doesn't inhale them and have some kind of reactions to them. So usually this mucus that the body creates, or the nose creates, is going to be thin and clear. And like I said, it's going to trap some dust, pollen, even bacteria and viruses. So when your mucus is thin, it pretty much moves down the back of your throat unnoticed. It's just like a constant flow of traffic, and you're not going to really realize it. You're going to swallow, just like how you swallow your spit, you're not going to realize that your mucus is kind of going down the back of your throat. That's why we have the little happy mucus. Now, when your nose gets irritated for any number of reasons, which we'll kind of discuss in a little while, the mucus becomes thick and yellow, and it doesn't have to be yellow. It could be green, it could be whitish, but it'll be thicker. And it flows, then starts flowing, you know, retrograde out of your nose and also down your throat. And that's when you kind of really start noticing, hey, there's something wrong with my nose. You'll start kind of coughing, or you'll start grunting or clearing your throat all the time. So I think we're almost done with the science, but I might be lying. We have just a picture in the background here to kind of give you an idea of a cross-section of what the nose would look like. Now, this is a very simplistic picture. It just gives you an idea of what this mucus would look like when something irritates the nose. The clear mucus kind of becomes all thick and soggy and boggy, and it kind of travels down out of your nose and back out the back of your throat, something that we call post-nasal drip. It can cause sore throat, and like I said, you can start clearing your throat a lot more, or coughing. So, like I said, more science. So what can cause rhinitis? Most commonly, it's going to be some kind of irritants or allergens. Now, allergens are, and many of you may already know that, so this is just to kind of get everybody on board. Allergens are just substances that can provoke an allergic response within the body. Earlier when I had mentioned, you know, you can breathe in dust, pollen, pretty much any kind of particle that you could breathe in could be classified as an allergen as long as it produces an allergic response in your body. So what kind of response are we talking about? To put it simply, it just causes, there are certain types of cells in your body. There's red blood cells that kind of mainly deal with oxygenation of your blood, give your blood the red color. There's white blood cells that are in charge of fighting for your body. They're the immune system of the body. Then there's platelets and other things. So part of the white blood cells, there are several different kinds, and one of those white blood cells is in charge of kind of surveying. You know, when you kind of go out of grocery stores, there's sometimes folks that are saying, can I look at the receipt just to make sure everything's there? That's kind of like what these white cells are for. They kind of look at all the allergens passing through your blood, and when they identify something that they have never encountered, they release certain chemicals from the cells to start a cascade of events that can produce an appropriate allergic response so that the body can protect itself. So here are just some examples of irritants and allergens. I guess I didn't go into irritant a lot, but an irritant, just like it sounds, is any kind of substance that will cause irritation. So on the left, if you see, there's just some major allergens. A lot of them are food related. So these are the major food allergens that whenever you encounter, maybe some of you do have food allergies, or you have some family and friends who say I have food allergies. These are pretty much I think these are the major, 16 allergens, I guess, that do cause allergies. Out of these, there's actually a classification of 8 major food allergens that are very carefully monitored because they're the most likely culprits to cause anaphylactic reactions and can cause folks to die within minutes, even with the most minute of injections or ingestions. On the right side, the picture is kind of showing different kinds of irritants, if not also some allergens embedded within that image. So, cigarette smoke would be an irritant, but a lot of the times we consider dander as an allergen or as an irritant. Dander just being skin cells that kind of falls off your pets, mostly dogs and cats. Some cleaning products, some of you may have noticed that maybe if you were ever in the past cleaning your bathrooms with bleach or something and you inhale a bunch of it, you start wheezing or maybe coughing, and that's pretty much the aerosolized form of the bleach causing or being an irritant to your respiratory system. Alrighty, so what kind of rhinitis types are there? So there's several different types, but if you had to classify them, there's acute and chronic. Acute usually means to us that it's less than a month, and chronic rhinitis will be something that happens for more than a month or more than 3 months. It doesn't have to happen all year long. For example, seasonal allergies only happen during certain seasons, and they can be chronic as in they only happen for 3 or 4 months a year, but they happen every year, so they would be chronic allergies. So let's look at the first. Here's just this slide as I was talking is just listing the different types of rhinitis. We have allergic, we have seasonal, perennial, meaning all year, non-allergic, and infectious. Okay, so this slide is pretty short. It's self-explanatory. Allergic rhinitis is caused by allergens, and again, allergens were these things that we were talking about. It's not an all-inclusive list, but just a few examples of the things that can invoke that immune response in your body. Next would be seasonal allergies or seasonal rhinitis. So this one is full of misconceptions, and we'll kind of take some detours and take a trip down memory lane through history. It's pretty fun. I didn't know a lot about this. And just doing research for this presentation was kind of helpful. So rhinitis traditionally used to be called hay fever, and it had nothing to do with hay exposure or fever specifically. The idea was more that exposure to hay irritated the body, but like I said again, even the very first examples being given had nothing to do with hay. They just started to associate it more with hay because I guess folks, when they went around hay, had more of a pronounced and documented history of being of showing allergies. So once people just got used to it, it was just easier to say hay fever than there were about 5 or 6 different names like catarrhal mucus, catarrhal fever, catarrhal illness. It just became easier for the public to say hay fever. And so it became the umbrella term for seasonal allergies. Now, it likely originated from the early 1800s, at least that's what Wikipedia and the website for the National Institute of Allergy and Asthma told me. the early 1800s were the first time that there was written documentation of the word hay fever. Of course, just like we do today, several kinds of cures or remedies were tried for hay fever, not with a scientific approach, as you can tell. These cures range from opium, vomiting, cutting your own skin to let the blood out, hoping that the allergens would follow or the sickness would follow. Mercury ingestion, which is obviously not a good thing. Inhaling chloroform. These were just some of the few things that were thought to be very effective in expelling the illness that hay fever caused in your body. Seasonal allergies or hay fever was also thought of as an aristocratic disease. So I think the reasoning behind this is the upper class was probably hygienic enough or wealthy enough to worry about things that bothered them, small things such as allergies or stuffy nose or runny nose. The majority of the population, the lower classes, probably were dealing with more hygiene issues, with hunger, with cholera, to really care or notice about why their nasal passages were stuffed. Another reason why it was thought of as an aristocratic disease was because one of the first times that allergies, nasal allergies or rhinitis was documented with royalty, it was a duke in England. A newspaper at the time had called it a vile thing, but then as more aristocrats or more royalty started getting infected or afflicted by seasonal allergies, they then changed the description to saying it's actually if I had to reword it, it was a cool thing to do because royalty obviously couldn't get something that was disgusting and not sought after. So because of this, a new trend started where having allergies was actually a cool thing to do, and it was a condition that was actually sought after in the elitist circles of 18th and 19th century society. Some other thoughts about hay fever, obviously they're not true, that it only targeted folks of Anglo-Saxon descent, and that it targeted the nervous system, which neither of them are true. Another thing that happened or that was documented was that in the U.S., folks who had hay fever started calling themselves hay feverites, and it was the cool thing to do. They started clubs and retreats, and they had specific retreat mansions or spas where key members or just a select few could retreat to a certain mountainside or to a certain valley where these allergens were either prominent or not, depending on whether they wanted a break from their hay fever or not. And we already talked about the vulgar disease. The last thing which I thought was interesting was they routinely recommended that folks smoke tobacco to relieve themselves of the symptoms of seasonal allergies, which we already know from a couple slides that tobacco is actually one of the worst irritants to your respiratory system. So, what kind of culprits are there for seasonal allergies? Pretty much everything in nature. Trees, grass, weeds. There's mold. I think that would be about it. Mainly, you expect seasonal allergies in the spring and fall seasons. But I guess depending on where you're geographically located, spring and fall happen to occur in different months. Just like north of the equator, winter might be winter for us, but closer to the equator or south of it, it might be summertime. So the next type of rhinitis would be perennial, meaning it lasts all year long. This kind of rhinitis is caused by, for example, dust mites, mold, animal dander, and cockroach debris. Dust mites are extremely common. They're everywhere. If you're sitting on a couch right now or even on your bed, there's probably thousands of dust mites on them. They're microscopic, and they're actually responsible for causing a lot of indoor allergies. If we're talking about indoor allergies, dust mites probably rank number one. If you've ever been to an allergist or been tested for allergies, chances are you came positive to dust mites, and there are specific things we can do to make your life easy, simple things that we'll kind of talk about later. So why cockroach? That's just one insect. Well, we'll go into that. Cockroaches are everywhere, and they live forever, and they shed forever. And for some reasons, our bodies don't like the debris that cockroaches leave behind. So, I'm going to try to say this properly. The INSECTOCALPYSE. INSECTOCALPYSE. Yeah. I made that word up, but I realized I couldn't really pronounce it. So insects, just a detour that we're going to take. They're everywhere. Everywhere. There's an estimated 1.5 million species. If we look at just ants, there's about 10 quadrillion ants, and that would kind of equate out to 1.4 million ants per person alive. The creepy thing is that they can live without their heads, and I'm not just talking about ants, I'm talking about insects. Most insects can live without their heads, and that's because they don't breathe through a specific nose on their head. Most insects have pores throughout their bodies that they breathe through. The only reason why an insect who's been beheaded would die after a couple of weeks will be because they failed to drink water because the head's not there anymore. But we're not here to talk about insects. We are here to talk about cockroaches. So, like I said, cockroaches also don't need their heads. They can keep on living until they die of thirst. So even if a cockroach loses its head somehow, it's going to keep running around in little circles or zigzags and leave all kinds of cockroach debris behind. Cockroaches can hold their breath for 40 minutes, so people that are saying, hey, yeah, we can fumigate that stuff, well, better hope that cockroach doesn't have a good lung capacity. They can run up to 3 miles per hour, so anyone at Butterfield Trail Village is fair game for cockroaches if they're hungry. They can grow into an adult in about a month, so their reproductive cycle is quick and very prolific. They love alcohol, so that gives me another reason to deter you all from drinking alcohol at your age. They'll come join you. And they've been around for about 300 million years, so they're not going anywhere. They can also not eat for a month, so that's why cockroach infestations are a big issue, and probably why cockroaches exist in such a huge number and all over the place. As to why our bodies specifically react to cockroach debris, I'm not sure. I don't think we've figured out the exact reasons, but they do, and they're here to stay. So, did I forget to move a slide? There we go. So we're next would be non-allergic rhinitis. I guess I was talking with Dr. Wright earlier today, and a few years ago at least, there were several different classifications of rhinitis, such as vasomotor. I think they've all been lumped into non-allergic now. Pretty much, the name is very self-explanatory, that if it's not a substance that's causing you actual allergies, it's just going to be irritants that kind of just irritate local tissue and cause symptoms instead of being inhaled, going through that screening by those cells and having like a body-wide response, an immune response. Funny enough, it is seen a lot with non-allergic asthma. So a lot of the times when kids or even adults go to their doctor and are diagnosed with asthma, then the specialists have to kind of determine, like, is this allergic asthma or non-allergic? Because the treatment differs based on that type. The next type would be infectious rhinitis. Now this, like I said, the allergic rhinitis was one of the most common, but the infectious rhinitis is the most common. Probably because human beings have grown to such a large number, and traveling is not an issue for us anymore. We can travel all over the place and carry our pathogens in a fraction of the time that we used to be able to. the same bugs that kind of cause those upper respiratory infections or the common colds are pretty much responsible for giving you the same symptoms of rhinitis. Most cases of rhinitis are from viruses, and it's really difficult to say when a person walks into your clinic to say, yeah, I think you have viral rhinitis, because you come in contact with possible allergens or irritants every day, from dust mites to pollen to cockroach debris. Maybe you smelled a certain type of food being cooked in the hallway that you're allergic to and that you're not aware of. So usually when we find rhinitis, there's a good chance it could be a mixture of causes, such as infectious and allergic or non-allergic happening. So besides the boring talk, I know everyone wants to know, how do you treat that stuff? Because no one likes calling Butterfield Trail Village Clinic 15 times a day. So this slide is a little bit of a text, so just bear with me. Best recommendations by the experts even today is avoidance. While a very practical answer, or a very simple answer, it's not quite practical. Human beings, as we know, we like what we like, and I think one of the reasons why a lot of medications were invented was for the sake of convenience. And because we like what we like, we're not going to stop going for walks outside, or we're not going to stop, eating certain foods that we want. So how can we stop or control our allergies? The next best steps are listed below. So you can take antihistamines. As far as I know, most or all antihistamines have become over-the-counter. If any new novel antihistamine comes out, they may make that prescription. But for the most part of it, first, second, third generation antihistamines are all over the counter. With our age group, meaning 65 plus, there are certain medications that we don't like prescribing to this this population or the group of folks, and Benadryl will be one of those. Benadryl is one of the oldest antihistamines, and one of its side effects, which really isn't a big issue for kids or adults, is drowsiness. But for the elderly, that becomes a big issue. If you take Benadryl, and if you're already drowsy to begin with, you're going to take a tumble and you'll break a bone, which is much easier in older age, and then be hospitalized for trying to prevent some allergies. So even if you don't need to ever call a doctor and you decide, hey, I'm going to go to the nearest pharmacy and get me some over-the-counter antihistamines, that's okay. There are certain classes, usually class 1, that are drowsy. The good thing for everyone is that when you look at the boxes, they will say non-drowsy, and they usually refer to second or third generation antihistamines. Just some antihistamines off the top of my head: Xyzal, Zyrtec, Allegra, Claritin. These are all non-drowsy. And like I said, if you're not sure about the names, just look for the non-drowsy label on the box, or just walk over to the pharmacist and say, hey, I want a non-drowsy antihistamine, and they'll direct you to some. Other things that can help you with your sneezing, itching, nasal stuffiness would be decongestants. They usually come in drop or tablet form. Decongestants can actually also now come in sprays. They are a very short-term solution. I've realized as a resident, I rotated through several specialties, and I've realized that primary care does not differentiate between the kinds of medications they'll prescribe you as long as they relieve symptoms. But specialists such as ear, nose, throat doctors and allergists tend to avoid decongestants in the long run, because decongestants are the kinds of medicines that your body kind of gets used to. They're similar to opioids, but they're not as detrimental as opioids are. What I mean is, if you use decongestants for more than a few days, let's say a few weeks, and you stop using them, your body will instantly react and congest itself up worse than usual. And that way you'll seek out the decongestant even more. It just becomes very dependent on it. The same doesn't apply to antihistamines, because those chemicals are pretty much recycled, just like the cells in your body are recycled on a daily basis. We have nasal steroids, which are the most effective medicine we've come up with in terms of relieving symptoms in the short term. Usually nasal steroids don't have long-term effects. They have a very low dilution of steroid in there, so I don't want you guys to confuse that with The oral steroids that you may have to take for certain conditions, or those steroids that the bodybuilders take, those are very high potency steroids. This spray, pretty much you spray it in your nose and it decongests within minutes, and for most people it's a long lasting thing. The most common side effect of nasal steroids will be dry nose and sometimes nosebleeds, which happens when your nose becomes dry. There's cromolyn sodium. Oh no, I skipped over one. Leukotriene receptor antagonist. Pretty much one of the chemicals, or one of the little soldiers that are part of the immune system that help propagate that cascade of immune response, is blocked. They're called leukotrienes, and their receptors are blocked, and that way they can't continue or pass on the message that there's something wrong. It just stops at a certain point, and so you don't really get that much of an allergic response. Cromolyn sodium is kind of like the same thing. Those cells I was talking about earlier that kind of go through the checkout line and say, give me your receipt, cromolyn sodium pretty much is a medicine that coats the cell membrane or the cell and tells it don't release any chemicals even if you identify something wrong. So it just kind of stops it at step one. Not as commonly used as far as I know, and some of the cromolyn sodium derivatives aren't even FDA approved in the US. So it's not usually the thing doctors will prescribe you first, and it's reserved for very rare or uncommon and fairly serious immune conditions. Last but not least is immunotherapy. This is a long-term thing. It's a commitment of 3 to 5 years. Let me change the slide for you guys. It's a commitment of 3 to 5 years, but it works for 80 to 90% of people. There's two kinds of immunotherapy right now in the US. There's sublingual. They'll give you some tablets with the allergens mixed in them. And then there's intramuscular injections, which has been pretty much the novel idea for over 100 years. So what they'll do is they'll take a little bitty piece of, let's say you're allergic to grass, and they'll start injecting it into your body every week in small doses. Then they'll increase the concentration over the next couple of weeks and months until your body's kind of used to them. Then what they'll do is just kind of space those injections out and let your body's immune system kind of adapt itself. What happens is that your body gets desensitized against these allergens, and over time you don't exhibit the symptoms as severely or not at all. Like I said, the process lasts somewhere between 3 to 5 years, and it is pretty successful. The downside of the sublingual tablet is that the FDA has only approved 2 different kinds, or 3 different kinds, so it's not really, when folks get diagnosed with allergies, they get at least 5 or more, so it's very specific and it's not as useful. So I think I'm coming to an end here. Rhinitis, what do I do to prevent it? Because we talked way too much about it. The best advice is, again, avoidance of things, but like I said, in the 21st century, that's probably not possible with all the people you come in contact with. You can stop touching your nose, that helps. This irritates the nose a lot. We can wash our hands with soap and water, but not too much, because if you do it too much, then your skin's going to get irritated, and you're going to come see us for that. For folks who live indoors, which is pretty much everyone, or independently, we can use vacuum cleaners once or twice a week, and some vacuum cleaners come with a special allergic HEPA filter that are very, very fine filters that can trap all these dust particles and dust mites, which will help your symptoms while indoors. If you have dust mite allergies, for example, or if you're allergic to pets and you still want to keep your pets, which is very reasonable, you want to wash your bed linens and pillowcases in hot water, not hot water, and with detergent once or twice a week. Try to keep the pets out of the bedroom. That's the best thing. Wear your sunglasses and wide-brimmed hats when you go outside. Sunglasses, I can still imagine. I don't see a lot of people wearing wide-brimmed hats, so that's okay. And keep the windows closed during high pollen and mold seasons. And I think that brings me to my end.
Great, thank you, Dr. Patolia. I want to remind everyone that we do take questions. We love having questions and trying to answer them. And often that's the most useful way of being sure you get the info and learn what you want to from this presentation. So the phone number, if you want to enter a question, and Dr. Patolia will answer it right now, is 479-200-9259. So 200-9259. Hope you'll call us. And now, Dr. Vo, who I introduced a while ago, is a native Arkansan. He's a first-generation American. So Dr. Vo's parents moved here in the 70s after the Vietnam War, and Dr. Vo came along sometime later. Okay, welcome, and this is the add-on. Dr. Patolia's told us it kind of covered everything about the nose, but often associated with these problems with the nose are problems with the eyes. And so conjunctivitis is an area that Dr. Vo is going to help us with.
Yeah, I just wanted to thank my partner, Dr. Jay Patolia, for really setting the stage, because now we're going to move on to the neighbor of the nose, the eyes. And you'll see there's a lot of overlap, but also some important distinctions to make between the two. So to start off with, I just wanted to discuss the area in specific that we're going to be talking about, the conjunctiva. So that's essentially the lining between the eyeball and the eyelid, and it functions to provide lubrication as well as protection to allow, for us to look around and blink our eyes without causing any irritation. It's also responsible for producing some of the tears that we have, and that in a way is a form of lubrication that allows us to function properly. So whenever conjunctivitis occurs, it's also known as pink eye, something that a lot of people probably know it better as, is when the conjunctiva becomes inflamed. Just like the nose, you can get inflammation for a number of different reasons. And primarily, we like to break that down into either infectious or non-infectious, again, like the nose. And then of those, about 80% are due to infectious causes, so majority of them are, and the rest are due to non-infectious causes. And the infectious causes can be broken down into viral or bacterial as well, and there's specific differences between the two that are important to note. And then in terms of non-infectious, you have a number of different causes, but again, the most common is allergic. So one of the most important differences that we can make in terms of conjunctivitis is how the eye looks. So with conjunctivitis, eyes are always red. That's one of the defining factors of conjunctivitis. But to further differentiate between them, you have a normal eye on the left, clear sclera. The white of the eyes are clear. There isn't any redness associated in the eye or around it. To the top right, there's bacterial conjunctivitis, where the hallmark is a purulent discharge from the eye, as well as the redness. And I'll go into details of all these in a little bit. In the bottom left, you have viral conjunctivitis, which produces a watery discharge. So it's pretty easy to tell the difference between viral and bacterial. And then in the bottom right, we have allergic conjunctivitis, which also produces a watery discharge, but the big difference there is you'll also have some itchiness, and that's one of the hallmarks that helps us see, tells the difference between that and the other causes. So to discuss viral causes more specifically, it accounts for about half of the infectious causes of conjunctivitis, and is commonly caused by a family of virus known as the adenovirus. It's a very common virus that occurs, that we encounter just throughout our daily lives. And in terms of transmission, the number one cause is contaminated fingers. So anytime someone rubs their eyes or put in their contacts or anything, they risk the chance of exposing themselves to the adenovirus. And also, there tends to be a period between July and September where this is most common. So we tend to see a larger number of viral conjunctivitis during this period. And in terms of differentiating it between all the other causes, the symptoms are the number one way that we can figure out what is what. So traditionally, it'll start in one eye, and oftentimes it'll spread to the other, just based on how contagious it is and how just slight manipulations can cause it to spread. Like I said before, it causes a watery discharge, and one of the key findings that make us think more of the viral cause is that it'll produce a burning, sandy, gritty feeling. So if you ever had that feeling, you probably know what I'm talking about, where you feel like there's something stuck in your eye and you'll rub it and it just doesn't seem to go away. You'll look to see if there's something underneath your eyelid and you won't see anything. And if that's the case, then chances are it's a viral cause. Fortunately, rarely affects the vision. So you'll notice, the redness and the gritty feeling, but your vision will still be intact for the most part, and you don't have to worry too much about any permanent damage. And another important thing to mention about viral causes is that a lot of times it's not just the conjunctivitis on its own. It's involved with what we call a prodrome, where you have other symptoms of a viral infection, whether it be fever, cough, runny nose, or other upper respiratory infections. So if you're having other symptoms that suggest maybe you have a cold or some other viral illness, and you develop redness in the eye with a watery discharge and a sandy, gritty feeling, then chances are they're all related, and they're part of the same viral infection. In terms of treatment, just like a lot of other viral infections, is mainly symptomatic treatment. There are not any antivirals or antibiotics or antimicrobials that are useful in treating these infections. Fortunately, though, a lot of them they tend to be self-limiting and don't really need much intervention. But in terms of relieving the symptoms, warm and cold compress can help relieve some of the redness and some of the other symptoms, as well as antihistamines like Zyrtec and Claritin, similar to rhinitis, like mentioned earlier. And then lubricating eye drops are also very useful in terms of re-lubricating the eye and minimizing the irritation. Something that a lot of people, tend to think of whenever trying to treat conjunctivitis is topical steroids. But in this situation, it's highly advised not to use topical steroids because it can cause damage to the eye and specifically the cornea and cause some thinning there, and then you can run into some problems with some vision changes. In terms of the prognosis, again, it's self-limiting. A lot of it will just resolve with time. And it's also important to note that in the first 3 to 5 days, symptoms may get worse, and that can be alarming for some people. But it's important to understand that after this 3 to 5 days, symptoms will improve and can last up to 2 to 3 weeks, but you should see an improvement, and things should start to resolve shortly after that. And then just reiterate, bringing up the close-up of the viral conjunctivitis, you can see the redness of the eye, the watery discharge, and then lack of itchiness around the eye, which will be discussed with the allergic conjunctivitis. Moving on to bacterial, common causes are Staph aureus, which I'm sure a lot of you are aware of, as well as other common bacteria that we find on our skin and everywhere else. So common cause for bacterial eye infection. Again, transmission is through direct contact. So it's also very contagious. And unlike viral conjunctivitis, there's no seasonal variation. So it can occur it can occur throughout the year without any specific period of the month or period of the year. In terms of the symptoms, bacterial causes start in one eye, and they can transmit to the other eye, but it's not as common as viral, not as easily transmissible through direct contact, but still possible. And the hallmark of bacterial conjunctivitis is the purulent discharge, the green, gooey, icky stuff that, I'm sure all of us has had it during our lifetime, where we wake up in the morning and we notice that our eyes are kind of stuck shut, and we try to open them up and they'll eventually give. And this is known as the eye stuck shut symptom. Another hallmark is that the discharge, if you wipe it away, it'll oftentimes reaccumulate within 3 to 5 minutes. So if this is the case, then high likelihood that it's bacterial conjunctivitis. And again, just like all the other forms of conjunctivitis, it rarely affects vision. So we can be confident that if you have this, then it's considered not necessarily an emergency. In terms of treatment, whenever we think of bacterial infection, we like to go to antibiotics. Fortunately, in this case, antibiotics are not necessary. They can reduce the duration of the symptoms if given early enough, and by early enough, within 6 days of symptom onset. Afterwards, it's less effective in terms of limiting the infection. But if symptoms are severe enough where it's bothersome, then I would recommend seeing a physician and getting some antibiotic drops to help with managing the infection. In addition, symptomatic management also holds true here. You can use cold or warm compresses, and that can help relieve some of the symptoms as you give it time to improve. In terms of prognosis, it's also self-limiting and typically will improve immediately 3 to 5 days. So it doesn't have that pattern of viral conjunctivitis where it'll get worse for 3 to 5 days. Rather, it tends to get better. So that's a lot more reassuring because you don't have to worry about that period of things are getting worse. Do I need to seek medical help? And again, it can last 2 to 3 weeks. So it is a little of a prolonged course, but just be confident that it will get better. And then again, showing a close-up of the bacterial conjunctivitis that's affecting an eye. You'll get the redness of the sclera as well as the green purulent discharge that is really, really hard to miss. It's pretty obvious. So, and moving on to non-infectious causes, specifically allergic. If this diagram looks similar as before, then it is, because a lot of the causes that can cause allergic rhinitis can also cause allergic conjunctivitis. And it just shows that there is a big overlap in terms of these two infections or two allergic reactions, and just shows that they all tend to be related in a way. You can have both conjunctivitis and rhinitis together. In terms of symptoms, you'll also get watery discharge. And then the most important thing that differentiates it is the itchy eye, where you'll, I think a lot of you have also experienced the, rubbing of the eyes, the redness that you get if you expose yourself to some of these allergens. And again, tends to be worse in the fall and the springtime whenever the exposure is the highest. You can also experience some runny nose, some congestion, other symptoms that are associated with allergies, seasonal allergies, and similar things. And again, rarely affects vision. So again, not a medical emergency. Treatment, like before, is to avoid allergens. I know that can be difficult, especially if we like to go outside, just like with rhinitis. But that's the kind of the main stage, is to avoid it if you can. Symptomatic management, similar, warm and cold compresses, antihistamines like Zyrtec and Claritin, and then lubricating eye drops as well. In terms of prevention, like I said, it's hard to avoid a lot of that stuff. But if you anticipate, spring and the fall, that you'll start to get exposed to a lot of the allergens that cause the allergies for you, then you can take antihistamines or mast cell stabilizers days to a week before you expect there to be exposure, and that can help tremendously with the symptoms. And then again, looking back at the diagram, you'll have the red eyes, as well as the red area around the eye as well, just indicating that it's more of a allergic reaction, and a lot of the allergies is more of a systemic type of picture rather than a focal infection. So in terms of conjunctivitis, there are certain important considerations that should be made. Prevention, it's difficult because a lot of times, by the time we develop it, we don't have a way to prevent it. But there are certain practices that, overall, it's just good hygiene overall that can minimize a lot of just infections and other badness. So wash hands if you're experiencing symptoms, and also wash hands if you're not, just to prevent the occurrence. Use clean washcloths, so change them out regularly, because debris and allergens and bacteria and other bad stuff can stay on this washcloth, and if we use them repeatedly, then that's just more exposure. Pillowcases, that's also something very important to change out regularly, because they can harbor a lot of the bad stuff as well. Eye makeup, it's fine, but if you're having symptoms, then avoid eye makeup, and if you do use eye makeup regularly, practice good hygiene. That includes changing out the instruments, the tools, the brushes regularly. And whenever you are having symptoms, avoid close contacts, at least for 2 to 3 days after you develop symptoms, because that'll limit a lot of the exposure to other people. And one important thing for contact lens wear is to practice good hygiene, because this is also one of the #1 ways to develop eye infections. So just change out your cases regularly. Don't sleep in your contacts. A lot of it's common sense. It's just a matter of remembering to practice good hygiene. And like I said before, conjunctivitis rarely affects vision, but if you experience any blurred vision, pain with bright lights, or persistent symptoms that aren't improving, then it's advised to seek medical advice, because maybe it's not conjunctivitis and it could be a deeper infection that involves more of the eye. And then the last thing I'd like to talk about is sinusitis. So again, related to the eyes, nose, is the sinuses, which oftentimes will act up in conjunction with the nose and the eyes. So sinusitis, simply just inflammation of the sinuses, commonly allergic or viral, and same bugs as before. Symptoms are pretty clear. You have nasal congestion, purulent discharge, facial pressure, and upper teeth discomfort, and you can have fever, although not always. In terms of viral versus bacterial, viral symptoms tend to improve in 7 to 10 days, and bacterial symptoms do not typically improve until a little bit longer. So if people are experiencing what they think is bacterial sinusitis, the go-to answer is to go towards antibiotics, and that can help, but antibiotics are not always necessary. Typically, they're only appropriate if there's no signs of improvement after 1 week, or start developing other complications such as eye infections, swellings, persistent high fever, severe headache, vision impairment, neck stiffness, and confusion. So that about wraps up everything for us. If you have any questions, feel free to give us a call and we can answer them.
Great, thank you, Dr. Vo. I hope this was helpful. I think it covered the very things I wanted to hear them review for you. I'm really glad Dr. Vo included the part on sinusitis. And the reason I say that is they're all kind of caught up together often, and you come in with rhinitis of whichever variety it is, and many people have the misconcept that this is, if it lasts long enough, and often these things do last a long time, depending whether they're allergy or viral or whatever, that it must be a sinus infection. And the truth is, it's a very small minority of people who have a sinus infection, but I'm glad he kind of reviewed the difference and the importance of it. It's very important for those minority of patients who do, but historically it's been, rhinitis has been overtreated with antibiotics, and if you've got a sinus infection, you'll be needing antibiotics if it doesn't go away pretty quickly, because it's likely to be bacterial, just as he said. But anyway, well, listen, one more pitch for the phone number if you'd like to call in a question, 200-9259, 200-9259. We'd love to, in the last 10 minutes, 5 minutes, answer your questions. In the meantime, let me just acknowledge a couple of things. One is I want to thank everyone at Butterfield Trail, including all of you who reside here, for your support of our efforts here. I hope it's been I consider it a great partnership between Butterfield Trail and UAMS, and I hope it is something that's been a win-win, that it serves you and your healthcare needs in a convenient way right here in the clinic, right on campus. I certainly think you're using us for that service is a huge thing for UAMS in terms of part of our postgraduate medical education of these young physicians. I could announce that starting in April, for the first time, we're going to have a medical student here every month, and that's an indication of growth of what we're doing here, and I think it's going to be a nice addition to what we're doing. I anticipate in the next few months to be able to announce that the clinic will be staffed by physicians 5 days a week, and every one of those days at least a morning clinic, if not an all-day clinic. So I think all that is testimony to growth and the fact that this experiment of bringing academic delivery of academic medicine and education to a world-class facility like Butterfield Trail can be successful. And we're not as busy as we want to be every day, and that's partly because of COVID. But now that everybody's getting vaccinated, I hope if you, over the next months, if you need help, don't hesitate to call us, because we want to be busy, and that's part of what demonstrates to our people upstream at UAMS that it's needed out here, and that we're serving a great purpose. So thank you again for your support. I feel it's such a blessing to us to be here, and consistently the feedback I get from our resident physicians is it's a great learning experience and it's a great place to be. So thank you for all that. And since there are no questions, I don't know how we've inhibited questions so terribly in this TV format, because when we were meeting face to face, as someday we'll do again, there would be 15 questions. And I still don't understand why people are less timid in person than they are by phone. But anyway, this is always fun, and I hope it's helpful to you. And any kind of feedback you have on our presentations, please let us know. We want to know how to do it better. If you would like a copy of the slides that the doctors were using for this presentation, just let Robin know at the clinic. She can print it out for you. She has their presentations. So with that, I'll say thank you, and look forward to seeing you. Bye.